So these are also known as tibial pilon fractures. The incidence is about 10% or less than 10% of lower extremity injuries. So these are relatively rare injuries. The incidence appears to be increasing as survival rates after motor vehicle collisions increase. The average patient age is 35 to 40 years, and they're more common in males than females. So this is a working population, typically as persons in the prime of their lives where their injuries occur to them. It's a high energy axial loading injury. That's an important differentiation here. That's different than a rotational ankle fracture. It's typically an axial load with severe soft tissue compromise, as you can see on the image on the right hand side with that massive fracture blister. These are often characterized by significant articular impaction, metaphyseal bone comminution, and associated soft tissue injuries. We think of these as a soft tissue injury that happens to be associated with a fracture. You certainly want to check for associated musculoskeletal injuries when you see someone come in with a high energy tibial pilon or Plafond fracture. So from a pathoanatomy standpoint, there are kind of these three classic ligaments that we talk about here. So those are the chaput or the anterolateral fragment, and each of these fragments has ligamentous attachments. So this chaput or anterolateral fragment is attached to the fibula via the anterior inferior tibiofibular ligament. The medial malleolar fragment here is attached to the deltoid ligament, and then the posterolateral or the Volkmann fragment is also attached to the fibula via the via the posterior inferior tibiofibular ligament or via the syndesmosis. So 75% of these injuries have associated fibular fractures. There's also a high incidence of, again, associated musculoskeletal pathology. It's important to note that the parameters that correlate with a poor clinical outcome and inability to return to work are typically a lower level of education, and this has been tested previously. This comes from a classic study by Pollock in 2003, JBJS, pre-existing medical comorbidities, male sex, work-related injury, and lower income levels. So those are all associated with lower or inability to return to work and a poor clinical outcome. So the distal tibia forms an inferior quadrilateral and pyramidal shaped surface with the medial malleolus as you see here. This articulates with the talus as well as the fibula at the fibular notch, as well as with the talar facet that you see here. The anterior tibial artery is the first branch off the popliteal artery, so it's a bifurcation off the top of the popliteal artery. It's going to pass between the two heads of the tibialis posterior and the interosseous membrane, and then it courses mainly on the anterior aspect of the interosseous membrane, and will then change its course to run between the tibialis anterior and the extensor hallucis longus just above the level of the ankle and terminate as a dorsalis pedis artery. The posterior tibial artery will continue in the deep posterior compartment of the leg. It courses obliquely to pass behind the medial malleolus and divides into the medial and lateral plantar arteries. There's more and more literature now with tibial Plafond fractures that this tibial artery, posterior tibial artery, can actually become entrapped in certain fracture patterns in between the posterolateral fragment and the medial malleolar fragment. The perineal artery is typically seen as it divides into the terminal branches, the perforating perineal artery, as well as the lateral calcaneal artery. This again runs in the deep posterior compartment, mainly along the posterior aspect of the interosseous membrane. The tibial nerve will cross over the popliteus and then split between the two heads of the gastrocnemius. It gives off the perineal nerve you see here, and then the tibial nerve running down the back of the leg there. It terminates as the medial and lateral plantar nerves at the level of the medial malleolus or sometimes just proximal to it. The muscular branches supply the musculature of the posterior leg or the superficial and deep posterior compartment. The common perineal nerve will cross just under the neck of the fibula. It will run around the neck of the fibula and runs deep to the perineus longus, and then it divides into the superficial and deep perineal nerves. We're going to see later in the talk, both of these are at risk during surgical exposures of the distal tibia. Okay, so now we're into the terminal branches of the perineal nerve. This is the superficial perineal nerve. This will come in through the lateral compartment. It will exit the fascia of the lateral compartment, and then it will course anteriorly to supply the sensation to the dorsum of the foot. More proximally, it supplies the muscular branches to the perineus longus and the perineus brevis, and then it terminates as the medial dorsal and intermediate dorsal cutaneous nerves. All of these are at risk during your surgical exposures for fixation of these injuries. The deep peroneal nerve courses along the anterior surface of the interosseous membrane along with the anterior tibial artery. It supplies the musculature of the anterior compartment and will give sensation to the first web space, which is a classic test to look for the deep peroneal nerve. The saphenous nerve is a continuation of the femoral nerve. It becomes subcutaneous along the anterior aspect of the medial aspect of the knee between the sartorius and the gracilis. It'll be typically running with the saphenous vein along the medial malleolus, and it will supply sensation to the medial aspect of the leg as well as the foot. The sural nerve is formed by cutaneous branches of the tibial and common peroneal nerves, and it lies along the posterior lateral aspect of the leg and the foot, typically 1 to 2 centimeters behind the fibula, and supplies sensation to the lateral border of the hindfoot as well as along the lateral border of the forefoot. Okay, so jumping into classification. So the AO-OTA classification is the most commonly used classification for these injuries. So A, just like most periarticular fractures, is extra-articular. B is partial articular, and C is complete articular. So to kind of dive further into that, again, B is partial articular, so you can see that here. That means that a segment of the joint is still attached to the main component of the metaphysis and the tibial diaphysis here. And there are different variations based on fracture severity and location. And then a C-type fracture, so I think you'll commonly hear that, a C-type fracture is that the articular surface is completely detached from the metaphysis and from the remainder of the shaft of the bone. So no portion of the joint is in continuity with the proximal bone. All right, so the Reddy and Allgauer classification. So Reddy and Allgauer initially described this injury. It was mainly in rotational injuries in skiers in the Swiss Alps. They came up with this classification, and they were the ones to really originally popularize surgical treatment of these injuries, whereas previously they had been treated with closed reduction, potentially Kirschner wires or some other similar device. So type 1 is essentially a non-displaced fracture. Type 2 is a simple articular fracture. Okay, so it has a simple fracture component, but the joint is incongruous, meaning that there's displacement of the articular surface. And then type 3 has comminution of the articular surface. So that's analogous to a C3 fracture of the tibial plafond. Okay, so the symptoms for this are typically pretty straightforward. There's not a lot of subtle presentations of a tibial plafond fracture. People have significant ankle pain, inability to bear weight, and they may have associated deformities. Inspection is really where the critical aspect of this comes in. You have to examine the soft tissues carefully in people that present with fractures of the tibial plafond. They may have significant damage or contusion to the underlying soft tissues. They may have abrasions, they may have fracture blisters, and they may have even subtle open wounds that are absolutely critical to evaluate and discover on your initial exam. You have to also look for associated musculoskeletal injuries. Don't get distracted by the obvious fracture. Someone comes in with a deformed leg, you have to make sure that you're not missing their spine injury or other associated pathology. Examine stability and alignment of the ankle joint. I wouldn't be too aggressive with that. The patient may not like you very much if you do that. You have to check for dorsalis pedis and posterior tibial pulses. It's not uncommon to have people who have a vascular injury with a tibial plafond fracture. There are studies showing up to a 25% incidence of sometimes asymptomatic vascular injuries with tibial plafond fractures. Look for neurologic compromise and certainly check for signs of a compartmental syndrome when someone presents with a high energy injury like this. Recommended x-rays, you want to absolutely image the joint above and below, get 3 views of the ankle. Certainly consider full-length views of the tibia and fibula as well. It's not uncommon with these injuries to have diaphyseal extension, so the fracture will extend up just beyond the metaphyseal zone and extend up further. It's important to rule that out. So a CT scan is incredibly helpful for preoperative planning. The majority of these injuries, as we will discuss shortly, are treated with initial spanning external fixation because of the degree of soft tissue injury. Therefore, we typically will wait until after the spanning external fixator has been applied to obtain a CT scan because there is some relative realignment of the bones via ligament ataxis or the intact soft tissue attachments to the fracture fragments. Non-operative treatment for these injuries is rare. typically involves stable injuries with no articular surface displacement or patients that are unable to tolerate surgery. In some situations, in patients that are at significant risk of skin compromise, either because of severe open injuries or because of conditions that prevent their soft tissues from tolerating surgery, we consider non-surgical treatment or more limited invasive techniques. So immobilization typically consists of a long leg cast for 6 weeks, followed by conversion to some form of a fracture brace and range of motion exercises. Alternatively, these people can be treated with early range of motion, perhaps with the use of a cast boot or a walking boot. Clearly, the intra-articular displacement and the fragments are unlikely to reduce with manipulation of a displaced tibial plafond fracture, and you're going to have to accept that articular malalignment to avoid whatever complication you are concerned about. It's common to lose reduction, and it's common to have issues with the soft tissue because you're unable to control the fracture fragments. Okay, so we're now jumping into our questions. So I'm not going to read the whole thing here, but I'm going to kind of paraphrase it here. You've got a 46-year-old person that fell 15 feet. All right, the injury is closed. There's no open fractures and soft tissues are intact. We're going to show the images here momentarily. Which of the following treatment regimens has been shown to decrease wound complications in the definitive management of these injuries? Okay, so here's the images coming up here. So hopefully everyone can appreciate this person has a severe tibial plafond or tibial pilon fracture, okay? There is significant articular comminution. There is shortening of the talus. So the talus should be ideally sitting underneath this here, right? This is a complete detachment of the articular surface from the tibial shaft and the tibial metaphysis. So this is a C3 fracture or a Reddy and Allgauer type 3 fracture. Okay, so let's see what do we select for our response here, right? So immediate plate fixation of the fibula and placement of an ankle spanning external fixation device, followed by delayed reconstruction of the tibia. Okay, so we're going to talk about that a little bit. I think this question may be poorly phrased, or at least the answer choices are poorly phrased. So one thing is very clear here, and this is tested time and time and time again. Staged treatment, that means initial placement of an ankle spanning external fixator with relative realignment and restoration of length of the limb is absolutely critical in the management that will allow for resolution of soft tissue swelling and then delayed open reduction and internal fixation. And this protocol has been studied. It's initially studied by both Cole as well as Patterson and Cole, as well as Sirkin, Sanders, and several other authors that looked at this, who demonstrated that this dramatically lowered the risk of soft tissue injury and soft tissue complications with the definitive treatment of these injuries. The thing that I would say, just as a quick point, the thing that I say that's controversial here is this thing about immediate plate fixation of the fibula. More and more, I think, in a trauma setting, we're getting away from immediate fixation of the fibula, and certainly if you're not going to be the treating surgeon and you're just applying the external fixator, I would discourage treating the fibula because you may place the incision in a place where the treating surgeon may not appreciate it ultimately. So sometimes we delay fixation of the fibula. Okay, so here we go. So you guys see the green highlight here. Okay, you see how many times this has been asked. Okay, so the initial management for a high energy tibial plafond fracture most commonly is initial placement of a spanning external fixator that crosses the ankle. So that means pins in the tibia, pins in the calcaneus. I typically prefer to include the foot as well, but that can be up to the treating physician. But you want to span the joint, realign the limb, regain length and alignment of the limb, and allow the soft tissues to calm down until the point where they are safe to undergo definitive fixation, which is typically at least 10 to 14 days and certainly can be longer than that in more severe injuries. Okay, so this is the paper right here. This is a stage protocol for soft tissue management. So Sirkin and Sanders, this was out of Tampa in 2004. Again, they looked at their stage treatment with initial external fixation followed by delayed definitive treatment. Average treatment occurred at 12.7 days. There was still fairly high complication rates. However, compared to the historical controls where these injuries were treated typically at the worst possible times at 2 to 5 days from initial presentation, this is a dramatic decrease in the rates of wound healing complications and infection. Okay, here we go again. 32-year-old male, pilon fracture, treated with a spanning external fixator, as we're going to show shortly. He's now 3 weeks out. Skin swelling has subsided. What do you do at this point? Okay, let's see here. There's the injury. Okay, so you can see we've got, again, a severe intra-articular fracture. Again, we've got a spanning external fixator. They chose to include the foot here. Again, there's no articular surface. It's in continuity with the shaft. It's a C3 fracture, Redi-Nagauer type 3. Okay, open reduction and internal fixation of the tibia and fibula. I think this is a fairly straightforward one. This is the standard treatment for these injuries. We convert them from their external fixator into definitive reconstruction, trying to achieve an anatomic reduction of the articular surface and typically relative stability of the metaphyseal component of the fracture. Okay, external fixation is a great temporizing treatment, but you can't get the joint right. Fixing the fibula can help to regain length and restore the anterolateral and posterolateral fragments via ligament ataxis, because remember, they're connected via the ligaments of the syndesmosis, the anterior tibiofibular and posterior tibiofibular ligaments. Again, we know that achieving an anatomic articular reduction gives the patient the best chance of achieving an excellent long-term outcome, knowing that these injuries have severe issues in the long term. Now it says here there's no role for primary arthrodesis in the young patient. I think that's a qualified statement. I think that there's some situations where the joint is not reconstructable, but I can say in the vast majority of these we do strive for an anatomic articular reduction. So the indications for open reduction and internal fixation, it's the definitive treatment for the majority of tibial pilon or tibial plafond fractures. So okay, so I'm going to read this line here. Limited or definitive ORAF can be performed acutely with low complications in certain situations. That's based on a study out of Canada, actually, that looked at immediate internal fixation of these injuries. That occurs in certain trauma centers. Again, take-home message from this topic, if anything else, stage treatment is the best initial management of tibial pilon fractures. Break time can return to normal at 6 weeks after initiation of weight bearing. Probably more so true for rotational ankle fractures, but has been tested for tibial pilons. Okay, so again, getting into the treatment of these injuries. So this is a great study. I would encourage you guys to take a look at this if you get a chance. This is in JBJS in 2003. So this is a study between shock trauma and Harborview. It was done in the early 2000s looking at the treatment of these severe tibial plafond fractures. This was the basis for that what we talked about earlier, the slide that shows that there's worse incomes in patients that have significant medical comorbidities, as well as patients that have a lower level of education and lower level of income. There are significant long-term functional consequences for suffering a tibial plafond fracture. So patients that had fixation of the tibial plafond fracture scored lower on all of their SF-36 scales. The take-home message from this is this is a life-altering injury for the vast majority of people that have to suffer a tibial plafond fracture. Oops, jumping back here. I think I moved a little too forward. Okay, so we have a 25-year-old female, motor vehicle collision. She has this isolated injury seen in figures A through D. Leg is swollen, but skin is intact. Okay, let's jump into our images here. Okay, so you guys will have a chance to read the treatment options here. This is a controversial question, I'll readily tell you that. Okay, so what we see here, we have a spiral or short oblique fracture of the tibial shaft. If you guys scrutinize here, we clearly have articular extension posteriorly, as well as a separate fragment that looks like it extends into the joint. Our CT scan shows a relatively simple fracture with a classic 3 fragments, anterolateral, medial malleolar, posterolateral. Simple articular extension, displaced tibial shaft fracture. So this is the answer choice here. This is an option for treating these injuries. This is not the only option. This is based on a study out of NYU that looked at immediate treatment with percutaneous fixation of the articular surface as well as medullary or intramedullary annealing of the tibial shaft component. It's a reasonable option, certainly not the only option. I think that this is a question, if asked again, can be challenged. I think that there are studies looking at fixation of distal tibial fractures showing equivalent outcomes with kneeling versus plating. So again, somewhat of a controversial question, but if you are asked, the explanation is that the patient has a minimally displaced articular component that can theoretically be managed with percutaneous fixation as long as you can achieve an anatomic reduction. And then the diaphyseal component can be managed with an intramedullary nail, and that avoids significant soft tissue complications. Okay, so external fixation alone may be indicated in select cases, mainly in patients that are unable to tolerate surgery or patients that have such severe soft tissue compromise that any safe internal fixation cannot be performed. As we talked about previously, this is so intramedullary nailing and percutaneous screw fixation is an alternative for simple articular fractures. So not an alternative for patients that have complex articular injuries. Okay, external fixation. So articulated versus non-spanning hybrid ring. None have been shown to be superior with respect to ankle stiffness. I think the vast majority of us that treat these injuries are placing a rigid, spanning external fixator that's not articulated. We typically place 2 tibial shaft half pins, although you can certainly place 3. You want to have an appropriate span above the zone of your injury so that your plate does not overlap your external fixator. We typically place pins into the calcaneus as well as pins into the foot to gain stability and 2 points of fixation. With hybrid fixators, thin wires can be placed within the joint capsule or within the zone of injury. This has been looked at previously. Okay, so soft tissues. Okay, so the Shaput fragment, as we previously talked about in the anatomy section, the Shaput fragment is attached to the anterior inferior tibiofibular ligament. So by placing an external fixator, you regain some relative alignment of the anterolateral or Shaput fragment by ligament ataxis. Okay, external fixation. Pros of it, clearly there's a decreased incidence of wound complication and deep infection. You can combine this with limited percutaneous fixation using lag screws. Interestingly, if you go back to that study between Pollock and the folks out of Harborview that we talked about in JBJS in 2003, that was a common treatment at shock trauma at the time in the early 2000s. And unfortunately, those folks did not appear to do that well. In fact, somewhat worse than the people who had definitive open internal fixation. So the cons of definitive external fixation, people can develop pin and wire tract infections. They get very stiff. They can lose ankle motion. There's a chance of injury to neurovascular structures with placement of your wires, and it's difficult, if not impossible, to achieve an anatomic articular reconstruction. Okay, so you can use multiple small incisions to do this. There's a multitude of approaches. The anterolateral approach is a workhorse approach. The direct anterior approach can be useful. It's certainly controversial in a traumatic setting. There are some proponents of it and then there's some strong voices against it. The anterolateral approach to the ankle is very useful for fractures that have valgus alignment and or anterolateral joint impaction. The reason this is important is if a fracture has valgus alignment, we typically want to buttress this side of compressive failure. So if the fracture is in valgus, the lateral side is undergoing compressive failure, and you want to support or buttress that side. That exposure puts both the superficial and deep perineal nerve at risk with the exposure and dissection into the anterior compartment. The superficial perineal nerve is at risk with the initial exposure. It's going to be right there as soon as you make your incision. The deep perineal nerve is at risk during the deep dissection as you elevate the anterior compartment musculature and sweep it from lateral to medial to unveil or to reveal the anterolateral distal tibia. Okay, approaches again. So in general, we must respect the soft tissues. You generally want to have about a 7 centimeter skin bridge. That being said, this has been challenged by a study. There's a great study out of Harborview that looks at the length between the incisions. Now keep in mind these were probably very short or small incisions, but they had less than a 7 centimeter bridge. That being said, the classic number, 7 centimeters between your incisions to preserve viability of the intervening skin bridge. Okay, here we go. Questions again. 34-year-old male, high-speed motor vehicle collision. External fixator for 11 days. Now it's safe to perform internal fixation. After removing the X-fix and fixing the fibula, what's the next step? Okay, here's our images here. Okay, so we have got here, I'm going to grab the pointer, high energy tibial, pilon, or plafond fracture. Overall alignment is varus. Okay, so you can see that there is a varus alignment to the limb. There's a large Shaput fragment, so you can't even access the joint unless you come way over here to the medial side. So those are all things that you keep in mind when you're planning on fixation of these injuries. All right, so the Basic question is what you would expect. So it's an anatomical reduction and stabilization of the tibial articular surface. So you have restored length, you've hopefully anatomically reduced your fibula because otherwise it's going to be very difficult to get the tibia right. And now you want to achieve an anatomic articular reduction. Why do we want to do that? Okay, so again, those figures showed a C-type pilon fracture, associated fibular fracture, anatomic reduction. So these are the basic steps: external fixation, soft tissue rest, delayed open reduction, and internal fixation to achieve the best possible outcome of these injuries. The goals: basic AO principles. It's a periarticular injury. Our goal is an anatomic reduction of the articular surface. Again, so reducing and instrumenting or fixing the fibula to establish lateral column length, becoming more controversial, certainly controversial at the initial surgical treatment, and I would seriously doubt that they would be asking that at this point. Reduction of the articular surface is critical, and then reattachment of the articular block to the metaphysis and the shaft. Typically that's done with relative stability because there's significant comminution or fracture fragments at the metaphyseal zone. Fixation can sometimes be augmented with external fixation. Sometimes you cannot safely place a plate in an area where you would like to because of severe soft tissue compromise, and therefore you can sometimes place an external fixator to support your articular reconstruction. There are multiple pathways to fix the joint. There's anterolateral, anterior, anteromedial, medial, posterolateral, posterior medial, direct posterior. You need to be familiar with the anatomy, and you can safely expose this in a number of ways. Fixation of the fibula can be performed with an intramedullary screw or plate and screw depending on the fracture pattern. Okay, the pros of an open reduction and internal fixation are what you see here. Anatomic reduction to minimize the risk of post-traumatic arthritis. Rigid fixation to allow for safe early mobilization of the joint to minimize stiffness. Clinical improvement can occur for up to 2 years. The cons are still, despite stage treatment, there is a high incidence of soft tissue complications and or infection. This is talking about without stage treatment. Even with stage treatment, there's still relatively a high risk of soft tissue complications with these injuries. Wound slough can be seen in up to 10%. This can require a free flap, dehiscence in 9 to 30%, infection in 15%. Varus malunion is common, and you would see that typically with patients with a varus initial injury pattern with insufficient fixation or medial buttress plating.
If you enjoyed this video, please consider leaving a like. We'd love to hear your thoughts and what you'd like to see next in the comments. Don't forget to subscribe to our channel and follow us on social media.